Post-nucleus removal cortical matter is being aspirated using the 22-gauge Simcoe's two-way irrigation aspiration cannula. Since the patient is a high myope, one can see the altered glow. The AC is deep and a relatively small CCC leaving behind deep fornices causing difficulty in cortical aspiration. After multiple failed attempts of aspirating the cortical matter, the struggling surgeon inadvertently grasps the posterior capsule, yielding the star sign. Fortunately, the surgeon notices the star, immediately stops further aspiration and performs a reflux, releasing the cort PC and saves its integrity. Once again in slow motion, one can see the radial lines on the PC as it is caught in the aspiration port. Noticing this sign has helped prevent a potential site-threatening complication. PCR may not always be a random error in execution, but it is more often a result of chain of events that lead to its manifestation. Unfortunately, this is often realized only in retrospect. This case demonstrates it well. The beginner phacosurgeon lacks the necessary ambidexterity and inadvertently makes the side port a little too flat into the corneal stroma. This leads to corneal hydration as the surgery progresses. All is well until the surgeon reaches the state of cortical cleanup. When he struggles to access the AC with his non-dominant hand, multiple attempts lead to use of strange maneuvers and force to enter the AC. Unable to stop his motion, the probe dips into the AC and pierces the posterior capsule. Post-nucleus delivery, cortex is being aspirated with a Simcoe's two-way irrigating aspirating cannula. When the surgeon reaches the inferior quadrant, cortex is aspirated in the periphery, where the fornices are shallow and the surgeon inadvertently catches the posterior capsule. Following this, there is a sudden withdrawal of the cannula outside the anterior chamber, which leads to AC shallowing and enlargement of the PCR and also drags the vitreous out into the wound. It is important to note that aspiration of the cortex should always be carried out in the central safe zone, and also as soon as a problem is sensed, a knee-jerk reflex to withdraw the cannula should be avoided to prevent such a catastrophe. A detailed preoperative evaluation cannot be overemphasized for the success of cataract surgery. In this case, the surgeon fails to recognize the posterior polar component of the cataract. And instead of following the inside-out principle of managing polar cataracts, the beginner hydrodissects after initial hydrodelineation. Also, multiple sites of hydrodissection create different cleavage pins, and a forceful injection causes the posterior capsule to blow out under the nucleus at the area of dehiscence. This, however, is only realized following the delivery of the nucleus. Therefore, a meticulous preoperative assessment and a thorough knowledge of all the techniques that are required to tackle different types of cataracts is a mandate to prevent this complication. Post-nucleus delivery, the epinucleus is visco-expressed out of the eye, and the posterior capsule is polished with a Simcoe's two-way irrigating aspirating cannula from the main incision. As the surgeon enters the anterior chamber through the main incision, the AC shallows and the posterior capsule is pushed upward and outwards. When the cannula is moved across the surface, the posterior capsule gets engaged in the sharp edge of the cannula, and with the high infusion rate, the PCR enlarges drastically. To prevent this, it is prudent to check all the instruments under the microscope before using them. It would be important to reduce the bottle height and the irrigating aspiration flow rate during the posterior capsule polishing. It is important to avoid random forceful movements and also make use of side ports to maintain a stable anterior chamber during this stage. In this case, following cortex aspiration, the IOL is injected in the anterior chamber. Then, viscoelastic substance is injected to create space, and with the help of Sinski's hook, the haptic of the foldable IOL are being placed into the posterior chamber. In doing this maneuver, the surgeon approaches the shallow fornix with a sharp tip, and when engaging the second haptic, the tip of the Sics key engages the posterior capsule. This, however, is only realized later when the viscoelastic substance is being aspirated through the main incision, which causes the anterior chamber shallowing, enlargement of the PCR, prolapse of the vitreous, and decentering of the IOL.